The fuck? Now we got the clear back. Welcome, everybody. We got the clear background. Waiting for the principals to arrive. How's everyone doing today? Testing, 1, 2, testing. Testing, 1, 2, testing. There is Andrea. Hey, good morning, Andrea.
Good morning. How are you?
Can you hear me? I
Yes,
can't
I
hear
can.
you.
Yes, I can. Yes.
I can't hear you. I don't know why. Can everybody, can you hear me, Andrea? Hello, Andrea, can you hear me? Hello, can anybody hear me?
Yes, I can hear you.
Okay, Joe, you can hear me? Word now? Great, okay. I don't want to get through half the webcast and find out I was muted. Hello, James, good morning.
Hi, good morning. Can you hear me?
I can hear you.
It's not letting me.
You
There we
were
go.
in there, James. I couldn't get you in. I guess you fell out.
Okay, now I'm on
Good morning,
the.
James.
Good morning.
I can't hear you. Can you hear me?
I can hear you loud and clear. Can you hear me?
I can't hear you. I don't know what's going on here.
Can you hear me, Andrew?
Yes, I can hear you.
Hold on.
Then maybe
Oh, okay. Can you
John's.
hear me now?
We can hear you.
Yes, we can hear you.
Can you
Oh,
hear
yeah.
us, John?
Yeah, there we go. Okay, I got it. Good morning,
Okay.
James. James, you ready
Good
to
morning.
start? Ready to start?
Yeah,
Okay, here we
yeah, we're
go.
ready to go.
Okay, let's go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett from Miami Beach, home of Neurosurgical TV. We have the sixth in the series of webcasts done by James Liu of Rutgers on, excuse me, the Art of Brain Surgery Masterclass. And this is the last of the six, which will be available on a playlist. And I'd like to introduce Andrea Castillo, a neurosurgeon from Nicaragua that's doing kind of a fellowship with James. Good morning, Andrea.
Good morning, everybody. Thank you, everybody, for being here. Today, we have a sixth of a series with Dr. Liu. Dr. Liu is Professor Director of Cerebrovascular and Skull-Base and Pituitary Surgery at Rutgers University, co-director of Endoscopic Skull-Base Surgery Program and the Department of Neurosurgery at Rutgers University. Good morning, doctor, and thank you for being with us this morning.
Good morning. Well, thank you for having me. It's a pleasure to be here this morning and to share with you some of my thoughts and pearls on craniopharyngioma surgery. So without further ado, let me share my screen. Okay, can you see my screen?
Yes, perfect.
Yes.
Okay, terrific. Well, this morning I want to talk about craniopharyngioma surgery. And craniopharyngiomas are very unique tumors, and they were described by the great Harvey Cushing as one of the most formidable challenges in neurosurgery. And the reason why is because of their deep location within the brain and their involvement with a lot of critical structures, namely the optic chiasm, which can cause visual loss, involvement of the hypothalamus, which is a very critical structure in the brain, involved with a lot of hormonal control, appetite control, and mood control. And also the involvement of the ventricular space, namely the third ventricle, and of course the pituitary function. So a lot of important real estate involved. And I can tell you from my experience that not all craniopharyngiomas are the same. Every craniopharyngioma has its own unique features. Every surgery on these is never quite the same, and they always present their own unique challenges. And so you have to be aware of the anatomy, you have to be aware of the pitfalls, and you have to really understand these tumors to know how to manage them and handle them at the time of surgery. So today, hopefully I'll dispel some of those tips and tricks and operative pearls on how to successfully remove these difficult tumors. You can see they come in different forms and flavors. A lot of them can be purely cystic, which is mostly fluid with a cyst wall. And these can be both easy, but also challenging for various different reasons. Most of them can be mostly solid, but a lot of them are mixed with a component of mostly solid and some cystic components as well. And so these can have its advantages, but also disadvantages on how to remove them. And we'll go over some of these things. From a coronal view, they can be wide, or they can be narrow, or they can extend just under the chiasm, or sometimes even go extensively as high as the foramen Monro, and sometimes extend even into the lateral ventricle. So we have to remember what our goals of surgery are. As with any surgery that we perform, it's important that we define what our goals are to help tailor the plan for the patient. So in this case, most would agree that a radical gross total or maximal safe total would be beneficial because we want to reduce the maximal tumor volume in order to decompress the optic chiasm to get visual preservation. But we also want to optimize the quality of life. And in order to do that, we have to avoid neurological injury to the optic chiasm to avoid visual loss. And we want to avoid injury to the hypothalamus and avoid complications of surgery, such as vascular injury and CSF leak. In terms of stalk preservation, we want to preserve the pituitary stalk when we can, if possible, but not every case of craniopharyngioma surgery allows us to do that because sometimes the craniopharyngioma tumor itself expands or invades the stalk, and we have to make a decision whether we can even preserve it, or if it's worth preserving, or if you're better off removing all of the tumor to get a curative removal at the cost of not preserving the stalk. And we'll talk a little bit more about that later. In terms of surgical approach, often the debate over the last 15 years has been whether to come transcranial from above or to come from below through a transsphenoidal approach. And with the advent of the endoscopic approaches, this has really been a game changer for endoscopic skull-base surgery, is the ability to better treat craniopharyngiomas, in my opinion. And so we wrote this paper some time ago about choosing the optimal surgical corridor or surgical approach in order to maximize the extent of resection and avoiding complications using a personalized, tailored approach. So when we think about the surgical approaches to craniopharyngiomas, I like to break them down into 5 categories. The first category is to come in anterolateral through this trajectory, and this can be a combination of terional, orbitozygomatic, frontolateral, or an eyebrow supraorbital keyhole approach, which gives you this trajectory. You can also come in midline through a midline transbasal, frontal-basal, interhemispheric, or subfrontal approach. And to get to the tumor, oftentimes we have to open up the lamina terminalis. And then less often used is this lateral transcranial approach, either through a subtemporal or a transpetrosal approach to get to the retrochiasmatic region. And for purely intraventricular tumors, oftentimes you may need to use a purely intraventricular approach through a transcallosal, transcortical approach into the lateral ventricle, or even through a translamina terminalis approach from the front. And then lastly, the approach that I think more and more people are using, myself included, is the endoscopic endonasal approach through an extended transplanum, transtuberculum, transcellular corridor. And we'll go over the details about that. So how do you choose and tailor the appropriate approach? Well, there's a lot of factors we have to look at. First, you have to look at tumor location. Is the tumor primarily prechiasmatic, retrochiasmatic, or is it purely intraventricular? What is the extent of the pathology? Does it elevate the floor of the third ventricle, or is it purely in the third ventricle? What is the relationship to the chiasm? If the tumor is prechiasmatic, oftentimes an open approach can allow you access if you have a post-fixed chiasm where the tumor is situated between the 2 optic nerves. However, if you have a prefixed chiasm where the chiasm is very close to the tuberculum and the tumor is situated behind the chiasm, retrochiasmatic, these are more difficult to remove through an open approach, but often are very favorable with an endoscopic and a nasal approach. We like to look at the relationship to the pituitary stalk, and they've been classified as pre-infundibular, transinfundibular, or retroinfundibular. And various approaches can have advantages for that as well. So the other thing I'd like to look at is also whether the patient has had prior surgeries, whether you're going to be working through scar tissue, or if you have fresh planes from a virgin case. And of course, surgeons' preference and comfort plays a big role. If you have not had a lot of experience with the extended endoscopic and the nasal approaches, and then maybe in one's hands, it may not get the best results, and vice versa. So surgeons' experience plays a huge role as well in contributing to one's surgical results. So just briefly, we talked about relationship to the stock, and this is from Amin Kassam's classification, which I often use, I think is very useful, is whether we look at these tumors, whether they're pre-infundibular. Now, pre-infundibular tumors, I believe, have a higher rate of successful stock preservation as long as the tumor doesn't invade the stock. And in my opinion, these type 2 transinfundibular tumors, often you cannot preserve the stock functionally or anatomically. These tumors often splay the stock open, and you often, in order to remove this tumor out successfully, you have to transect the stock just at the base, just above the pituitary gland, in order to successfully remove these. Retroinfundibulars are more difficult. The stock is often in your way. Many people have proposed doing a pituitary stock transposition to get these tumor out. Sometimes you have to work around the stock, and sometimes you may need to consider sacrificing the stock to adequately remove the tumor. And then type 4 is the purely interventricular tumors, and these often require a transventricular approach through the ventricular system, through the lateral ventricle, through a transfrontal or a transcallosal type approach to get here. So I share with you, this is my first case I did in practice nearly about 16 years ago. And this is before I was very comfortable or even familiar with endoscopic endonasal approaches. And so I chose a orbitozygomatic Sylvian approach. And for this large tumor, you could see this is the view that I got. And what we're looking at is a subfrontal view. This is the optic chiasm. This is the pre-chiasmatic space, and this is the tuberculum. So you could see this is a prefixed chiasm. Here's the carotid artery, here's the optic nerve, and here's A1. And here I'm looking at this and I'm like, where's the tumor? You don't see any tumor here. I thought a transcranial approach will get you here, but if you understand the anatomy of craniopharyngiomas, these are retrochiasmatic in location. So in order to expose the retrochiasmatic space, you have to work either prechiasmatic, carotid, optical carotid triangle, carotid oculomotor triangle, or you have to open up the lamina terminalis. So you can see here that we had to open up the lamina terminalis. The corridor was quite narrow. You have a blood vessel here. We then have to work between this corridor. This is the optical carotid triangle. And these corridors are quite narrow. And, I had a very difficult time excising the tumor, and we left a rather reasonable residual tumor there, which recurred. And I had to go back and come back a couple of years later and do a midline transbasal approach. So when we look at the scans, it's very important to look at the T2 sagittal. And when you look at the T2 sagittal, we'll try to look for where the optic chiasm will be in the relationship to the pituitary gland. I often will look at the distance to see how much of the tumor presents itself to the infrachiasmatic window. And if there's a considerable portion here and the trajectory appears good, then an endoscopic and a nasal approach through the infrachiasmatic window can be favorable. But sometimes if it does not present itself too well here, you may get minimal tumor removal, in which case you must consider a lamina terminalis approach from above. So if you look here, the corridor here is bigger. So here we chose a lamina terminalis window. This is the case that we chose. This was a 52-year-old male who had weight gain over 6 months, having visual loss and endocrine abnormalities. And when we look at the sagittal scan here, you can see this is the chiasm. This black dot is the chiasm. And so here, the lamina terminalis window was bigger. And so we published this technique on the transbasal translamina terminalis approach. We do a bicoronal incision, elevate a large vascularized pedicle pericranial flap. And the transbasal approach, I like to incorporate the anterior wall of the frontal sinus so that the bone flap opening is along the contours of the anterior skull base. Remember, the anterior skull base is not a flat line. The earth is not flat. It's actually peaks, valley, and peaks, and it correlates to the orbits. The orbits are the peaks, the cribiform is the valley, and the orbit is the other peak. So that you don't have this bony overhang when you're trying to look down into this corridor, you don't have this bony overhang obstructing your line of sight. So if you come in orbitozygomatic or pterional and you open up the lamina terminalis, your view of the lamina terminalis is oblique, meaning you're able to see cross-court to the contralateral hypothalamus and third ventricle, but you're blinded to the ipsilateral side because you cannot see it because it's hidden by the ipsilateral optic tract. But if you come in transbasal, you have a midline approach and you have equal access and equal opportunity to both sides of the third ventricle and hypothalamus. So if you come in lamina terminalis, I believe the transbasal approach is the better approach for these reasons. So here's the video showing us opening that lamina terminalis, finding the craniopharyngioma, and now we're peeling it off of the white shiny walls of the ependema, of the walls of the third ventricle. And after the tumor is fully freed up, we can now remove it from the lamina terminalis. Now there is the basilar artery. You can see the basilar artery in view here. And the summary shows the progression of how we remove the tumor. However, the limitation is always the blind spot. So the blind spot here is the undersurface of the chiasm. It's very hard to see if there's any tumor attached on the other side of this chiasm through this approach. So oftentimes you can use a dental mirror or an endoscope to look around the corner here, but the dissection of this area is often blind. And so blind dissection can be risky. You can injure vascular perforators on the undersurface here, resulting in visual loss. And you can also leave residual tumor in this area. So this is the initial post-op scan, very favorable. I was very happy with this scan. Patient did well. But you can see there's two dots of enhancement here. Wasn't sure at first if this was little residual. But if you follow these tumors long enough, they will eventually recur. And so here, after a few years, we saw some early recurrence. But fortunately, we were able to treat it with stereotactic fractionated radiotherapy, which controlled this tumor and prevented any further progression. So why is the EEA favorable for the retrochiasmatic craniopharyngiomas? And this is the view from above, and this is the view from below. So the major advantage, in my opinion, is that you have this ability to see that blind spot that you had from above, so that you can see this undersurface of the optic chiasm and optic nerves. You can visualize the small perforators going to the chiasm. You have a direct view of the backside here, which is the hypothalamus. And so this view you don't get, and it's unparalleled, and you don't get this from the open approach. So this is a case of a supradiaphragmatic craniopharyngioma. She presented in the emergency room with acute headaches and was thought to have pituitary apoplexy. But instead, she had this tumor, and I was told by the resident that this was a pituitary tumor, pituitary apoplexy presentation. And when I pulled up the MRI, I said, no, this is not a pituitary tumor. This is a diaphragmatic tumor. If you look carefully, this is the gland. This is the diaphragmatic cella, and this is the pituitary stalk. So this is a tumor that's arising from the pituitary stalk that's primarily supracellular, supradiaphragmatic. Notice how the cella turcica is not expanded. There's multi-cystic appearances here in the retrochiasmatic space. So this, I concluded, was a craniopharyngioma above the diaphragm and not a pituitary tumor. Now, this is important because for pituitary tumors, we often take this route through the transcellular corridor. And if you did that, you would find normal pituitary gland and you would miss the tumor. But in order to access this tumor, you have to do a endoscopic transplanum transtubercular approach, go above the diaphragm to visualize this tumor. So the operative pearls for success, we often will use a 30-degree angled endoscope. And the endoscope is pointed upwards to look up into the ventral skull base so that when you're placing your instruments, you should put your non-dominant hand, which often is the suction, in the 12 o'clock position in the right nostril if you're a right-handed surgeon. And then your tools, whether it be a drill, dissector, or some kind of aspirator, into the left nostril in your right hand if you're a right-handed surgeon. And so if you put the scope in the 6 o'clock position, looking upwards with a 30-degree scope, you put your instruments at the 12 o'clock position. And so this is the view of the ventral skull base. This is the planum, the tuberculum. This is the cellar dura that's been opened, and the clival recess is here. So always know where your carotid arteries are so you avoid vascular injury. When you're making your bony opening over the planum sphenoidale, remember, it's not a rectangular opening, but rather a trapezoidal opening, because you're going to skeletonize the optic nerve canals as you go farther back, and then it becomes more of a trapezoidal shape. Some people have called this a chef's hat opening. Looks like an upside down chef's hat. And so this is the opening. You could see here. Here's the planum dura, the tuberculum chiasmatic sulcus bone has been removed. Here's the optic nerve canal, cellar dura. And when you open the dura, above and below the intercavernous sinus, and then you cut the intercavernous sinus, which is the same as the diaphragmacella. You cut the diaphragmacella into the suprasellar cistern, and you get this great opening where you see the optic chiasm, and then here's the tumor in the retrochiasmatic space. The first thing you want to look for is to look for the carotid arteries. Here's the left carotid artery, and then we see the first medial perforator off of the carotid artery. This perforator is incredibly important. This is the superior hypophyseal artery, which will give an arcade of vasculature with a branch going down here to the pituitary stalk, or the remnant of the pituitary stalk in this case, and then a perforator to the optic chiasm. And you really must preserve this perforator so you avoid vascular ischemia to the optic chiasm. If you coagulate this thinking it's a tumor feeder, you will cause postoperative visual loss or even blindness. So very important. It's also very important to maintain the arachnoid planes and to understand the arachnoid structures around pathology in the suprasellar region. So with craniopharyngiomas, understand that there's generally two layers of arachnoid. There's a tumor arachnoid, which is the arachnoid just adjacent to the tumor capsule. And then there's the cisternal arachnoid, which is the arachnoid on the cisternal side next to the neurovascular structures. So when you mobilize the arachnoid, it's like a curtain. What you want to do is when you see the tumor, you want to peel the curtain and move the curtain from the middle to the sides so that the arachnoid is now mobilized laterally to protect the carotid artery, the PCOM going back to the basilar, and all the small perforators. So notice how this carotid artery has a veil of arachnoid membrane over it because the arachnoid has been mobilized from the tumor capsule. We've undressed the tumor And we've mobilized that curtain to the lateral side to the carotid artery to protect these. So we have a clear dissection of the tumor. You don't want to be dissecting in the arachnoid planes, leaving the arachnoid on the tumor and skeletonizing the vessel on its native adventitia. If you follow that arachnoid membrane, it becomes contiguous with the membrane of Lilliquist. The membrane of Lilliquist is what protects the basilar artery, the P1 and P1 perforators. And I would say the vast majority of craniopharyngiomas generally respect the integrity of the membrane of Lilliquist. So you can peel the tumor off of the membrane of Lilliquist. How do you find the pituitary stalk? Well, you can find the gland, which has a classic yellow appearance. And if you lift the tumor off of the gland, we look for these portal striations, which is characteristic in the pituitary stalk. And you could follow it as it goes to the hypothalamus. So in this case, you can see the stalk is rather preservable. And if you lift up, we can look back, and here's the basilar artery, and here's the third nerve. Now, in terms of preserving the stalk, I generally have adopted this philosophy from the late Professor Edward Oldfield. He wrote this very nice editorial that in order to minimize tumor recurrence, a complete surgical removal is the most effective way to avoid recurrence. And if it means that it's at the cost of sacrificing the stalk, then you have to accept hormone replacement therapy, which is an easy fix, assuming the patients are compliant to medications. And he says that even if you preserve the stalk, in most cases, the function of the stalk is not even working. So you end up on hormonal therapy anyway. So in his opinion, it's best to choose a complete tumor removal and accept pituitary hormone replacement therapy. Now, I take that with a grain of salt, and of course, I use it judiciously on a case-by-case basis, and I'll show you various examples. So this is an example where you can see here the tumor has expanded the stalk. There's no preservable stalk. Here's the stalk, and then here's the tumor. You lose the stalk. It's nowhere to be found. You have a big tumor. And so this is the video showing that. So here we're opening the dura after we've drilled out the planum sphenoidale. And then we're going to open up the intercavernous sinus and the diaphragma sella to get into the suprasellar cistern. And then this is a primarily cystic craniopharyngioma. And cystic craniopharyngiomas are both easy and hard. What is the easy part? Well, it's easy to collapse and decompress the chiasm because it's all full of fluid. But the hard part is once the cyst is collapsed, it's like working with an empty bag, and there's no turgor, there's no solid feedback, there's no countertraction. So you're trying to dissect this saran wrap off of the bottom of the chiasm. Here's the mammillary bodies. And this plane is very difficult to define because it's all collapsed. You don't have any counter resistance to help your dissection. So here we're looking at the bottom of the third ventricle. You can see some CSF coming out. And I had a hard time getting this cyst wall off. Finally, I used a Fukushima ball tip probe. This is the Ichiban dissector. And this is beautiful. This is we were able to start peeling the cyst wall off of the undersurface of the chiasm. Here's the third ventricle. And here's where I transect the stalk. You can see it's I had a hard time mobilizing it. And the stalk, you follow it, it disappears into the tumor. So here we have to transect the stalk in order to get the tumor out. And then using this ball tip dissector, I'm peeling the cyst wall off of the chiasm. You can see it's this thin membrane. And this membrane is part of the tumor. You have to get all of the cyst wall, otherwise you'll have tumor recurrence. This is where it was most adherent. I couldn't get this part off. It was like wallpaper, so I trimmed it and then removed the rest of it, knowing that there's probably a small microscopic residue on the chiasm here. So here we are delivering the rest of this tumor. And then here's a beautiful view. Here's the A1 vessels, recurrent artery of Hubner. The chiasm is nicely decompressed. And of course, there's probably a microscopic residue right here where it was most difficult to dissect. And so we have a direct view. Another advantage of the endoscopic approach, like I mentioned, is you have a direct view of the hypothalamus. You don't have this beautiful view from a transcranial approach. And it's very important to resist the temptation to want to prematurely deliver the tumor. You have to ensure that all of the adhesions around the tumor to the hypothalamus, to the critical structures, are entirely free before you want to take the tumor out. So once you've ensured that, you can now safely deliver the tumor from the opening, get this beautiful view of the third ventricle. Here's the basilar artery, P1's mammillary bodies, cerebral aqueduct. This is the hypothalamus back here. Here's the beautiful view of the third ventricle, very classic view after removing these retrochiasmatic craniopharyngiomas. Here's the foramen of Monro, cerebral aqueduct, hypothalamus. And we're in the final stage of the operation, which is the closure. Remember that the closure is just as important as the tumor removal, just as important as the endoscopic approach. We have to have a exit strategy. We have to close this defect so you don't get CSF leakage complication. So how do we repair this? We published a multi-layered strategy, which is what we typically use. I like to use autologous tissue, the fascia lata, which heals very well. We'll often use 2 layers of fascia lata and supplement it with a vascularized nasoseptal flap. And our CSF leak rates have been rather low, only 2 in our entire series. Our series is probably up to 35 cases now or so or more. And this is a schematic or photographs actually showing how we put the fascia lata over the defect, hold it in place with Surgicel, and then we'll supplement it with a nasoseptal flap. So here's a video showing the actual technique. Here we take the fascia lata and put some Surgicel to hold it in place. And then we'll take a second layer of fascia lata. And fascia lata has a stickiness to it. It's human tissue. It's our own tissue from the patient. And it's got a little stickiness, so it holds in place and it heals rather quickly. Lately, we've been using taco seal to hold the fascia lata down before putting up the flap. But you want to ensure there's no seepage or leakage of CSF before you put the flap up. If there's still some leaking and you put the flap up, chances are that flap is going to fail. There's too much pressure pushing the flap out. A couple of tricks that you can do is I put the patient in reverse Trendelenburg to lower the CSF pressure while you're doing the repair. And the other thing is, as the patient is getting extubated, you should open the lumbar drain so that when the patient coughs or bucks as the tube is coming out, the CSF that's being coughed out comes out of the lumbar drain instead of out of your repair. So it's important to follow them in the office. Our ENT team, Dr. Eloy and Dr. Shea, they debride these gel foam and crusts so that eventually you get this nice mucosalization of the skull base, a nice, excellent repair, no CSF leak. And so here's a view of this repair at 2 months. And then here's the pre-op and post-op. You can see this is that supradiaphragmatic case. You see how there's no edema, no manipulation of the hypothalamus. This is a complete removal and no recurrence. So choosing the appropriate corridor is incredibly important. This is the case, a similar case where if you look at this carefully, this is not all of the tumor here. This is the tumor up here, and then this is the normal gland. So it's important to know that this is the diaphragm, this is the gland, and then this is the tumor. So you have to use a transtuberculum transplanum approach, not a purely transcellular approach. Now, this patient unfortunately went to an outside facility where the surgeon did a transcellular approach and basically did a pituitary biopsy and missed the entire tumor entirely. And so, of course, the tumor recurred, causing more expansion, more compression on the optic chiasm. And so we chose a endoscopic endonasal approach for this, but this time using the transplanum transtubercular corridor. You can see it's partially calcified. So here we're drilling the transplanum bone, drilling the tuberculum sellae, and then we're opening the dura above and below the intercavernous sinus. Once we get into the tumor cyst, you can see the classic greenish motor oil fluid with cholesterol crystals extrudes out. This is typical craniopharyngioma crank oil fluid. And like I said before, the cystic tumors tend to be more challenging because once the cyst has collapsed, it's a little bit difficult to dissect it off the critical structures because you don't have the counter resistance of turgor on the tumor that can give you the resistance you need against your instruments. So you're working with a floppy bag. But here you can see, we're able to see the stalk. Here's the pituitary stalk. It's behind the tumor. So this is a pre-infundibular tumor. And you have to use sharp dissection to carefully dissect away the tumor from the critical structures. And after we remove the tumor, we have a beautiful view of the third ventricle. Here's the pituitary stalk. And then the repair here, we'll put a little Duragen inlay and then a fascia lata overlay, and then the nasoseptal flap. And so the nasoseptal flap has been a game changer for preventing CSF leaks for endoscopic skull base surgery procedures. We'll bolster it with Surgicel and some gel foam and a Miracell pack. And then here's the post-operative MRI scan. Look at the optic chiasm. Look how it's nicely decompressed here. Restored the patient's vision, and we preserved the patient's pituitary stalk function, which you could see as an intact stalk. This is a 12-year-old boy, pediatric case. You can see multicystic, multisolid cystic tumor. Extends all the way up to the foramen Monroe. Quite a sizable tumor. He was panhypopit with short stature, and he was already gaining obesity. It's a sign that his hypothalamic function has been impaired. And so we published this technical video showing how we're cutting the dura above and below the intercavernous sinus. And we open up that diaphragma sella, getting into the suprasellar cistern. Here is the carotid artery on this side. Here's the frontal lobes. And so we already see the tumor here. We're now debulking the tumor using a side-cutting tumor aspirator. Here's the optic chiasm. You can see it's going back to the retrochiasmatic space. We're going to collapse the tumor some more by debulking it, and then using my non-dominant hand, using a technique I call suction dissection or suction sweeping, using your suction as a dissector to tease off the tumor attachments off of the hypothalamus, then coming in with a dissector, dissecting the tumor, You can see as I'm dissecting the hypothalamus, it's under direct vision. I can actually see the attachments to the hypothalamus and then carefully sweep away and dissect the tumor. Once you've ensured that the tumor is entirely free, now you can safely deliver the tumor. Again, avoid and resist the temptation of early delivery before ensuring that all of the tumor attachments have been freed, so that you would avoid any untoward avulsion of a vascular perforator. So here is the hypothalamus, third ventricle view. Here's the foramen Monro, cerebral aqueduct. This was a transinfundibular type 2, so the pituitary stalk was not preservable here. But we use a 30-degree scope to look around the corners. We can look and see the carotid artery. Here's the base of the pituitary stalk that was transected. And then here's the lamina terminalis pulsating. We kept the integrity. Here's the basilar apex. You can see the basilar and the P1 vessels. And then this is the defect, which we'll show. And then this is the repair, multi-layered repair with the fascia lata and putting up the nasoseptal flap. And then we'll bolster it with Surgicel and some gentamicin soaked gel foam pledgets. And then an expanding Miracell pack that we leave here for roughly about 10 to 12 days. And then our ENT colleagues will take these out in the office at that time. So here's the post-op scan. You can see excellent decompression of the optic chiasm. And he has been over 10 years recurrence-free now. And he's actually now a grown adult living a normal life. This is a young child, 7-year-old girl I operated on doing live surgery in Mexico City. You could see this is a mostly cystic tumor with a solid component at the very top. And we were able to do a complete removal. She was already pan-hypopit preoperatively. And she's been probably 5 years now recurrence-free, doing quite well. This is a mostly cystic tumor, progressive, very severe visual loss. And I've shown you the video here already. This is the one where the cyst wall was completely adherent to the chiasm. And she was recurrence-free, but that small remnant I showed you did recur eventually. I had to do repeat surgery. And this time I added radiotherapy because of the recurrence. And since then, she has been recurrence-free. So what if people have had previous craniotomies? Craniopharyngiomas are notorious for having recurrences. This is a patient who, during her childhood, by her pediatric neurosurgeon, was treated with 3 previous craniotomies, 1 microscopic transsphenoidal. During one of the craniotomies, she had a right carotid injury and she was blind in the right eye. And now she's an adult, and her care transferred to me as she no longer followed up with her pediatric neurosurgeon. And now she has this cystic tumor that's grown quite large, and she's had 4 prior surgeries, multiple complications. She's blind in one eye. What is the approach? Can an endoscopic endonasal approach be performed even if you've had previous craniotomy? Well, the answer is yes. And so this is one we came in endonasally because the tumor presents itself down low under the chiasm to the sphenoid sinus. So here we've emptied out the cyst, and then this is the cyst wall. And can we stop here? Can we just merely drain these cysts? Well, the answer is no, because that's what was done in the 4 prior surgeries, where only the cyst was drained. An aggressive removal of the cyst wall was not performed. And you can see the cyst wall is so thick now because of multiple surgeries, multiple scar tissue formation. And the cyst wall was like a rubbery, fibrous cyst wall. I was able to remove the cyst. And here is the only remaining left optic nerve available. She's only visually functional in one eye. And I left a tiny little remnant that appeared to be stuck right onto the medial wall of the cavernous sinus. And this was what I call a 99% near total removal of the tumor. Here's the nasal septal flap with the repair. And then this is the progression of the surgery. This is the cyst wall. We drained it, and then we were able to identify a plane around the cyst wall and start peeling it off of the structures, peeling it off of the optic nerve. And then we left a small remnant that was stuck here to the cavernous sinus. I didn't want to injure the carotid artery. And so if you've had multiple recurrences and you did a radical near total, knowing surgically you probably left a little remnant, but you don't see it on the MRI scan, it will probably recur. So how do you prevent it from recurring? Well, I treated the remnant of it with stereotactic radiosurgery, and she's been recurrence-free for the last 10 years now. This is the longest period she's gone through her lifetime without having a recurrence. So I've not had to do any secondary operation on her. This is an interesting case. This was a case of a mostly cystic tumor, suprasellar in extension. What was interesting is that the pattern of visual loss was a right homonymous hemianopsia. This is unusual. Most patients present with a bitemporal hemianopsia, but if you have a right homonymous hemianopsia, if you remember your neurology diagnosis, or your neuro-ophthalmology rather, you will know that the lesion is arising from the left optic tract. And if you look carefully here, notice how the chiasm is here. The tumor extends off to the left, and it's actually invading into the left optic tract, back into the left hypothalamus. And so here's the video showing the endoscopic and the nasal approach. This is the right carotid artery. This is the tumor in the retrochiasmatic space. Here we're debulking the tumor. The cyst has collapsed. And so now we're dissecting the cyst wall by using a little bit of gentle traction in our right hand, and then using suction dissection, suction sweeping technique with our left hand, and then using the tumor aspirator to remove and debulk portions of the tumor. This is the remnant of the cyst wall. And here we are resecting the remainder of that cyst wall. And then you can see this is the optic chiasm, left optic nerve, and then this is the optic tract. Look how the tumor went into the optic tract, into the hypothalamus, and now we're mobilizing that wall back. There's the third ventricle. There's the origin of the tumor in the left optic tract, explaining the pattern of visual loss. And here's the post-op scan. Excellent vascular reconstruction. You can see the nice enhancement of the nasal septal flap. I think people who are doubters of the endoscopic approach tend to say, well, I don't think endoscopic approach can treat these massive tumors. And so the question now becomes, can EEA treat these large craniopharyngiomas? And I would argue that yes, they can in the properly selected patients. You could see the endoscopic endonasal trajectory is going to come through here. And notice how this is the optic chiasm. This portion of the tumor is cystic. So you know that this portion is going to collapse and it's going to fall down rather easier than if this was a solid component. If this was a solid component up here, I would say, and if the solid component didn't deliver down, it would be probably more difficult. But if it's cystic here, you have a better chance of getting this endoscopically. Same thing with here laterally. You see how the lateral components are cystic. So for those reasons, we chose an endoscopic approach, and you can see we're working here in the retrochiasmatic space. Here's the third nerve. Here's the hypothalamus. You can see the tumor is adherent to the wall of the hypothalamus. You can see how it blends in. And so you could use sharp dissection looking for that transitional zone between the normal neural tissue and the gelatinous transitional zone and cyst wall of the tumor. And we're going to use sharp dissection. And then once the tumor is free, we can now safely deliver the tumor out of the nostril, removing this large piece of tumor, and then getting this final view, beautiful view of the third ventricle, spectacular view here of the foramen Monro and the hypothalamus. So here is the post-op scan. She presented with hydrocephalus. So we actually put in an external ventricular drain. Now, this is an important nuance. If the patient has hydrocephalus, obviously you don't put a lumbar drain in, but you put an external ventricular drain in. And if you have existing hydrocephalus with high pressure and you do an endonasal approach, we monitored her CSF output at a height of 10 and a height of 15. And it was putting out 200 to 300 cc's of fluid, even at a height of 15. And so I did not dare clamp the EVD and challenge her, because once you clamp the drain, she'll present with a CSF leak. So we went ahead and upfronted, shunted her, because we knew that she would probably fail based on the CSF output volumes. So you want to avoid a CSF leak because of that. This is an example of another large tumor we did with retrochiasmatic location. This was primarily mostly solid, and this was a papillary craniopharyngioma, much less common than the adamantinomatous cousin, but a nice decompression and complete restoration of her vision. This one, you can see, has a huge cystic component in the right frontal lobe, a lot of mass effect and shift, and a purely solid component here in the retrochiasmatic space. So I debated as to which approach to choose, and my initial thinking was I can decompress the optic chiasm better with that solid component coming from below. So we went ahead and did an endoscopic endonasal approach as my first go at it, as opposed to a transcranial approach. My thinking was that I would come from below first and see how much I can get. And so here is the those vascular perforators. This is the left carotid artery. You see this small artery? This is the superior hypophyseal artery. So you have to preserve it. It's not a feeder going into the tumor. And here you can see the solid tumor is wrapped around the chiasm and then forming that cyst in the frontal lobe. So at this point, I'm thinking this is going to be hard to get a radical removal. So I changed my strategy. I'm going to do a maximal safe resection as much as possible. I'm dissecting the tumor away from the hypothalamus here. And then here is the pituitary stalk. I can see the striations of the pituitary stalk going up to the hypothalamus. I'm able to dissect this tumor free. And then there's the basilar artery. Here's the pituitary stalk. There's the tumor. And then I'm able to remove the tumor here. And then this is the frontal lobe. You can see this cyst wall is plastered to the frontal lobe. You can see the cyst wall is plastered over the ACOM, over the recurrent artery humor. So removing this portion of the cyst wall would be rather dangerous. It's very adherent, like wallpaper. And so I do my repair, put up the nasoseptal flap, and there's the reconstruction. Beautiful nasoseptal flap, no CSF leak. And I preserved the pituitary stalk, so I was able to preserve pituitary function. She had transient DI, needed only about 1 dose of GDAVP, and her optic chiasm was nicely decompressed. But look how the cyst wall is collapsed. And this is the immediate post-op day 1 MRI. I rechecked her MRI at 3 months, and you can see the cyst wall has collapsed even further. And so my debate here was to either come in transcranially and remove the rest of the cyst wall, or should I just radiate it? And since I knew that the optic chiasm and the ACOM complex was plastered with the cyst wall, I knew I couldn't get a radical removal. So I went ahead and just treated it with radiotherapy. And you could see at 16 months post-op, the tumor has regressed quite nicely here. And we published this combined strategy of maximal endoscopic removal with early radiation therapy for this complex tumor. And this raises the question, what is the role for early radiation therapy for subtotally or near totally removed tumor? Remember that near total is basically means you've left tumor, even though if it's a small microscopic remnant. And craniopharyngiomas are notorious for recurring. So when do you radiate? Should you watch and wait for the tumor to recur and then radiate, or should you radiate up front at the 3-month mark after things have healed? So this is a case where I did a endoscopic removal, but the top part of this tumor was hidden behind the ACOM complex. You can see it's right behind the ACOM. There was ACOM perforators here, and I couldn't safely get to this area. It was rather adherent to the vessels. And so I did a subtotal removal. And at 3 months, it's already grown bigger. The residual has grown bigger. And so I treated it with radiation therapy, and look, the tumor's regressed, almost nearly disappeared. You don't see it anymore at 2 months post-radiation. Here's another example. This is an 18-year-old male who had endoscopic endonasal approach, treated with radiation therapy. And you can see he's been 9 years recurrence-free. This is another 17-year-old male who had this combined cystic and solid craniopharyngioma. Patient was treated by her pediatric neurosurgeon with an Ommaya catheter. That's the catheter that goes into the cyst where they drain it. So you have to keep draining these, otherwise the cyst recurs. So it's not a curative treatment. And of course, you can see the cyst kept recurring. The Ommaya was not working. So we came at it endoscopically. Of course, this portion of the tumor is very difficult to reach endoscopically. This is the limitations. You can't really safely go into the proximal sylvian fissure, going lateral to the carotid. So we left a residual here, and we treat it with radiotherapy, and you can see we've had excellent control over the last 6 years, recurrence-free. And this is the data from Mitch Berger showing excellent progression-free survival, overall survival with adding radiation therapy. So this brings the question of, when is the open approach necessary? You know, the vast majority of the cases I showed you have been endoscopic endonasal, and in my practice, it has dominated the treatment of all these midline retrochiasmatic craniopharyngiomas, which is about 90% of my series. But when is the open approach necessary? Well, when you see a tumor like this, where the tumor is not midline, but extends quite laterally into the sylvian fissure, this is a transcranial approach in my mind. I like to do the modified orbitozygomatic, open up the sylvian fissure widely, and then get access to the tumor here in the carotid oculomotor triangle. We left a small remnant that was adherent to the optic nerve, and the rest of this was treated with fractionated radiotherapy with excellent tumor control. This is a tumor in an 80-year-old female. She had a previous left pterional and was left blind from the previous surgery at another reputable institution. And because of the remnant of the tumor, it continued to recur, and it recurred as a progressive cystic and solid component. Another institution put an Ommaya catheter in to drain the cyst, and she would have periodic aspirations from the Ommaya, and It was failing because the fluid was so thick, the crystals were occluding the catheter, and now she's left with this tumor. So we decided to treat this transcranially, but she's 80. I didn't want to do an endonasal approach. I thought it would be inadequate, and plus you would have to wait for a repair. The question is whether she should have radiation therapy now or try to decompress the tumor further. So the solution that I decided on was to do a right-sided transciliary eyebrow approach, do a mini invasive craniotomy so I can get her in and out of the hospital quickly. And from this approach, we came in transcortically first to remove the cystic portion of the tumor, because the cystic portion of the tumor is in the frontal lobe. So we removed this portion first, and we can dissect it from the frontal lobe structures. And this is no different from removing a glioma or a metastatic tumor in a transfrontal, transcortical trajectory. And after we remove that portion of it, we come in subfrontally and open up the prechiasmatic cisterns. You can see the tumor here is extremely adherent, a lot of scar tissue. You have to use sharp dissection to dissect this tumor away. And I cut it away in a piecemeal fashion so that I can make room to dissect more. You don't want the tumor in your way. You want to break up the tumor in smaller pieces. You can see the tumor is rather adherent here. We don't want to injure the A1 or the recurrent artery of Hübner. And so we're going to dissect it away from the frontal lobe and then continue to trim it and cut it into small pieces. And here we are lifting up the tumor with the suction and trimming it some more. Trimming more pieces of the tumor. And this is all sharp dissection. Now, the tumor is very scarred down to the optic nerve. And one of the tricks that I've learned is that when tumors are scarred down to nerves, you could cut right along the scar tissue with an arachnoid knife, and the scar tissue gets released from the tumor capsule. Look how the tumor is nice and smooth and encapsulated, and the scar tissue will now get mobilized towards the nerve. So I'm not causing any traction on the nerve. I'm using this trick by undressing the tumor. If I cut sharply on the scar tissue, that scar arachnoid layer will fall towards the side of the neurovascular structures, and I can safely remove the rest of this tumor this way. And here's the last portion of the tumor. So now here's the A1 vessel, ACOM complex. I can look through the transcortical corridor and looking at the ACOM complex through the transcortical corridor, and then mobilize the brain and look at it through the subfrontal corridor. This is the reconstruction. We use a little bit of hydroset cement for cosmesis. And this patient had a near total removal. We then sent her for radiation after doing a radical removal. And you could see she left the hospital in roughly 2 days with an excellent outcome. This is the other indication for the open approach. Look at this giant multicystic tumor. The tumor is wrapped around the A2 vessels and it extends laterally into the Sylvian fissure. Not a great approach for endoscopic endonasal. It'd be very difficult to dissect these tumors off of the vessels. You can see it's wrapped around these A2, ACOM complexes. And so we chose a transbasal interhemispheric approach. You can see the cyst wall is completely wrapped around the A3s. So you have to carefully dissect in the interhemispheric fissure and sharply cut these cyst wall adherent bands to the vessel. But look how the cyst wall is still wrapped around the vessel. And we cleared the tumor from the ACOM complex, and then we removed as much as we could through the retrochiasmatic corridor. But even then, the opening was very limited. So I got a 95% removal. This tumor was very adherent, you could see, to the undersurface of the chiasm, but overall got a nice decompression. At 3 months post-op, this patient recurred. You can see the tumor has recurred, but this time it's recurred back into the retrochiasmatic space. So again, we asked the question, can an endonasal approach be used in a patient who's had previous craniotomy? And the answer is yes. We come in endonasally. Here's the chiasm. We're working in the retrochiasmatic space, removing the tumor. And we had to leave this very thick adherent piece of calcium to the optic chiasm, but overall got a very nice resection, a spectacular view of the third ventricle. And we treated her with radiation therapy, and she was recurrence free for approximately 7 years after that. A little side note on global neurosurgery. This was a medical tourist from Nigeria. She was visiting her family, and she was going to go back to Nigeria, but she came in with this massive craniopharyngioma. But she also has a planum olfactory meningioma here. So we can come in endonasally, but if we come in endonasally, we have the risk of CSF leak. And if she had a CSF leak and was in Nigeria, there's no qualified ENT to treat her with a CSF leak. So that would be a bad situation. So instead, we come in transbasal. We can treat the meningioma at the same time we treat the craniopharyngioma. And using the lamina terminalis approach, we got a complete removal. And you could see very nice resection. And she was able to go back to her country safely without a CSF leak. So important nuance. And lastly, I want to show you this variation. This is the multiple cystic tumor. It was pan-hypopit. We chose an endoscopic approach here. You can see it's multicystic, involving the hypothalamus. We do a transplanum transtubercular endonasal approach. We coagulate the intercavernous sinus. This is the gland. Then we cut the dura opening. And now we can see the tumor. Now look at this perforator. This is that superior hypophyseal perforator. This is the perforator going through. There's not a lot of working room here. I want to preserve this perforator. This perforator made the surgery extremely challenging. So here I'm going to puncture the cyst wall, but not drain it. I'm going to leave as much fluid as counter-pressure turgor as I carefully dissect away and remove the cyst wall. So here I'm dissecting the tumor. Here's the solid component of the tumor. We have to be careful about the vascular perforator here, and we're able to mobilize the tumor and work around that perforator, keeping the perforator intact. And then removing the rest of the cyst wall in a piecemeal fashion. Here's the rest of that tumor in the retrochiasmatic space using a suction dissection technique, separating the tumor from the hypothalamus. Using gentle traction in one hand and suction dissection in the other. Removing this last portion of the cystic wall. Here's the final view. Again, a beautiful view of the retrochiasmatic space. There's the third ventricle. Beautiful view of the third ventricle. There's the left oculomotor nerve. There's the basilar artery. And then here's the fascial lata closure with the nasal septal flap reconstruction. So this is the pre-op and post-op. This was a near to gross total. There was a little gelatinous tissue adherent to the right hypothalamus. We've been just watching it very carefully, and she hasn't recurred for 4 years now. But the pathology was a papillary craniopharyngioma. So this is very important because if the tumor does recur, we have the option of radiation therapy, or we can also use the option of chemotherapy, because we know that papillary craniopharyngiomas have the BRAF mutation. And so there have been papers and trials showing response to BRAF and MEK inhibitors using chemotherapy for tumor recurrences. And here's another paper showing a good response to this tumor that recurred in this region. That was a papillary craniopharyngioma. So in conclusion, when I look at craniopharyngiomas, these very difficult, deep-seated lesions in the skull base, the vast majority of them can be treated successfully through an endoscopic endonasal approach, particularly if they're midline retrochiasmatic location. But you need to have both expertise and open approaches as well. You got to be an open and endoscopic surgeon treating craniopharyngiomas, because not all of them are amenable to endoscopic endonasal surgery. As I've shown you, there are some occasions where the open approach is better. So you have to have good knowledge of anatomy, surgical technique, and team experience. I think adjuvant radiation therapy is an important role, and especially if you as the surgeon know that you left a little remnant behind, that remnant will most likely recur. And so radiation therapy plays a big role, as well as molecular targets for chemotherapy, especially the papillary variant with the BRAF mutation. So thank you again for your attention, and welcome any questions.
All right. Thank you, Dr. Liu, for that amazing lecture. Once again, giving us very important pearls. Craniopharyngiomas are very difficult tumors because of their recurrence rate. We have one question, and it goes, in the context of craniopharyngioma resection via EEA, what is the preferred surgical strategy? It is optimal to first perform extracapsular dissection of the tumor, maintaining the integrity of the tumor capsule, or it will be more beneficial to first debulk the tumor and then focus on the capsular planes?
Great question. I think the answer is both. So when you first open the dura, first you have to manage the arachnoid and the hypophyseal artery and perforators. So at this point, after you open the dura, you want to understand where the arachnoid is, and then open the arachnoid and peel the arachnoid like a curtain so you can mobilize and protect those perforators. And then you want to start the extracapsular dissection as much as you can, just to establish the planes. And then I like to establish the separation between the tumor and the chiasm, because that's where it's most adherent. Once you get underneath the chiasm, it starts to become a little bit less adherent. And if you can get past that without debulking, you have the best counter pressure. But you have to make a judgment. Sometimes you have to debulk a little early to make room, but sometimes you can begin your dissection. But you'll know when you reach a limit that you start to lose space, and it starts to become a little risky. So at this point, you start debulking, and you want to debulk in such a way that you don't want to lose the surgical handle. The surgical handle is that ability to pick up the plane again. So if you debulk too much, you lose the handle, and it's hard to get back into that surgical plane. So it's a combination of both.
Thank you very much, Dr. Lu. Does anyone has a question for Dr. Lu?
Hello,
Hello, Dr. Harshad. How are you?
I'm fine, Andrea. I'm very well. Hi, James. Once again, we are meeting. Wonderful talk as always. James has got a wonderful technique and very thrilling to see that majority of cases we can do through the endoscopic way. And we have understood that the visual deterioration is more common in cases when we do transcranially than the endoscopically. It is very well known. So it is very important to learn this technique of endoscopic removal of a craniopharyngioma. My question to you is that when you open the dura and you are opening the arachnoid, you have to safeguard the perforators. And many times it's difficult to visualize the perforator even in endoscopically. Otherwise, you will lose the vision. So what is the best way you do to preserve these perforators going maybe from the artery itself or maybe perforators coming from the endal carotid to the optic chiasm? How do you do that?
Thank you for your question. You want to find the origin, which is from the carotid. So if you find the origin of the vessel on the medial side of the carotid, that confirms that that's the hypophyseal vessel. And then you follow it towards the center of the exposure, and you want to look for where the perforator goes up to the chiasm. There'll often be a branch that goes up to the chiasm and then another branch that goes to the stalk. Now, sometimes if you have to free up the perforator, you can coagulate and divide the branch that's going to the stalk, but do not divide the perforator that's going to the chiasm. And then you want to do your best to mobilize that vessel so it creates more working space for you to be able to actually work on the tumor. But you have to do your best to preserve that, don't injure it. Be very careful with your suction strength. Use Fukushima teardrop suctions to control your suction strength. Control the suction strength on the suction canister. We use the Stryker suction system, and you can change the strength of the suction from the suction machine as well, because suction can cause injury as well. So be careful with that, and be careful with your instrument dissectors.
Do you always able to remove the calcified portion of the tumor? Many times I have noticed it is stuck to the vessel and difficult to separate it out. What is your experience?
Yes, great question again. There are some calciums that you can remove. So the calcium that's easier to remove is the portions that's right on the tumor or the calcium that's speckled on the cyst wall. But there are some patients who have like rocks of calcium, which is either stuck to a vessel or stuck to the optic chiasm, like I showed you. Those you have to leave. Don't try to remove that. You're going to most likely risk injuring those structures. And oftentimes the calcium is not the neoplastic portion of the tumor. So even if you leave the calcium, if it's only calcium and there's no cells in the cyst wall, it's not going to recur. So leave those dense calciums behind.
Do you believe in putting an Omaya reservoir and decompressing the cyst and then go for excision, or don't bother for that?
I would say don't bother with that. You're just delaying the true definitive intervention. Some people have advocated that. I've heard and seen other colleagues to say to do that, but I think it's just an added unnecessary procedure that it doesn't help much. You can decompress the cyst when you remove the tumor.
In what percentage of cases you found some deterioration of vision post-op?
I've had one case of pretty bad deterioration. This was early on in my career, and it had to do with the superior hypophyseal perforators. I mistaken the perforators as a tumor feeder, and these are not tumor feeders. You have to follow it, and eventually you trace it. It's going to go backwards and then up into the chiasm. So you have to preserve these.
I agree with you. Don't try to remove the calcium which are adherent to the vessels or nerves. Otherwise, you will end up with injuries. Leave the calcium behind. And even for a cyst wall, I have noticed many times it is adherent. Very difficult to remove the cyst wall completely. This is my experience. What do you feel?
Yeah, cyst wall removal is like removing wallpaper. So you can remove some of it, and then at some point, the most stickiest part of the cyst wall gets stuck, and it tears away from the rest of the wall that you're removing. And it's hard to remove the rest of it if it's stuck to an important structure, such as the chiasm or an artery. And in those cases, you have to leave the wallpaper stuck to the wall, and then you could treat it with radiation therapy. But the good thing is that I believe that if you do a maximal removal, a radical near total, and then treat it with radiation therapy at about 3 months, your chances of local control are quite good.
Right. If the tumor is more retrochiasmal, does your approach changes for a transpenoidal, transnasal?
No, it doesn't. In fact, if it's retrochiasmatic, more reason to do endoscopic transnasal.
Right. I mean, bony removal.
The bony removal? No, my bony removal is the same. My bony removal, even though we say the approach is an endoscopic transplanum, transtubercular approach, my bony removal is always standard. I remove the planum, I remove the tuberculum, and I remove the cellar floor. So even though we don't say transcellar in the definition of endoscopic endonasal, I always remove the cellar floor because you need control of the dura below the intercavernous sinus to control the diaphragm. But you also need control of the gland because sometimes you may need to remove a portion of the gland to get the right trajectory to the tumor. And that's very safe to do. Or sometimes you have to do a pituitary gland transposition to get access to parts of the tumor that you wouldn't be able to.
Right. Very nice demonstration, and very pleased to see your techniques. Wonderful as always. You have got a wonderful technique of transpenoidal. I've heard you, and now for a craniopharyngium also. Do you have to drill the clivus when you are doing a large cases, large tumors, which are retrochiasmal?
I have not had to on any of my cases, but I have seen some colleagues that have done that. Professor Ohata from Japan has some nice cases where he has drilled off the dorsum sellae, which is the very top of the clivus, and it depends on the anatomy of the tumor. So some tumors may require that, but I have not had to use that on any of my tumors.
Any chance of mobilizing the pituitary gland to go to the tumor?
That has been described by some groups, but I have not had to use that technique for this tumor. If it presents itself nicely to the retrochiasmatic region, infracellular region, the working space is generally adequate in that area.
Okay,
Thank
thanks,
you.
Harshad,
Wonderful.
for all your interaction. That's great. Okay, Andrea, back to
Oh,
you.
James is wonderful. James is wonderful. Thank you.
Thank you. Thank you for your comments.
Thank you very much, Dr. Hasher. We also have a question from Daniel from the audience. It says, thank you for your wonderful talk. What is the role of intracystic interferon therapy for recurrent cystic craniopharyngiomas?
That's a great question. I didn't cover intracystic therapy, but an option for cystic craniopharyngiomas is the use of putting an O'Mara catheter into the cyst and injecting a type of chemotherapy. The types of chemotherapy that have been used are interferon, radioactive P32, and also bleomycin. These are various drugs to theoretically obliterate the cyst. I think the overall long-term control is not as good as maximal surgery plus radiation therapy. I don't think we have, I think a good study would be to look at the literature head to head for that. Now that you got me thinking about it, I think I will write that paper. But yeah, the thing about I don't have a lot of experience with intracystic brachytherapy, but there have been reports of toxicity you have to be aware of and be careful of, especially bleomycin that has caused some bad hypothalamic injuries before. So you do have to know about the risks of that, and the long-term control, in my opinion, is not great. They're still at high risk of recurrence. So surgery is always the best option, and to get a gross total, radical total, and if not, try to get a radical, safe, near total, and then treat the rest with radiation therapy.
Thank you very much, Dr. Lu. Does anyone has any other question?
Okay, I
No.
guess we can wrap it up. Andrea, thanks for your help, and thanks, James. That's the 6th of the series, and we're gonna put a link on the chat where you can access those 6 in the series that James did. Okay, very good. James, thanks for the series.
Thank you.
Thank you very
It will be accessible.
Thank you very much, Dr. Lu.
Okay, bye-bye.
James, before you go.